10 days. That is how long it took China to build a fully equipped 1,000-bed hospital in Wuhan. 1,000 beds, full ICU capacity, negative pressure isolation wards, a functional sewage treatment system, and a fiber optic network. 10 days from bare ground to military handover. America's last comparable hospital took 11 years to approve, not 11 years to build, 11 years to get permission to begin. That gap is the subject of this video. It is not an engineering gap. It is not a funding gap. The reason China can do in 10 days what America cannot do in 11 years has nothing to do with the people building it. This is the channel that examines what infrastructure actually costs and why. Subscribe and tell us in the comments, what do you think is the real reason America builds so slowly? In 1946, the United States passed the Hill-Burton Act. The law provided federal funding to build hospitals in underserved areas, and it set the legal architecture for how American hospital construction would be governed for the next 80 years. It created a system of review, approval, community consultation, and environmental assessment that was, at the time, a genuine reform. American hospitals had been built chaotically, often in the wrong places, often without adequate infrastructure, and occasionally in ways that harmed the communities around them. Hill-Burton was supposed to fix that. It did. And in doing so, it created a regulatory structure that cannot move faster than its slowest approval stage, regardless of the emergency occurring outside the window. That structure is the original sin of American hospital construction, not the engineers, not the contractors, not the workforce, the process. Here is what that process looks like at full speed. Erlanger Medical Center in Chattanooga, Tennessee, broke ground on a new patient tower in 2021. It had been in the planning and approval phase since 2010, 11 years between the decision to build and the first concrete pour. The facility was not controversial. It was not opposed by the community. It was not technically complex beyond standard hospital construction. The delay was not caused by a single obstruction. It was caused by 47 separate approval processes running sequentially, each with its own timeline, each capable of restarting the clock. To understand what those 47 processes actually involve, it helps to walk through what a single one of them looks like in practice. A standard certificate of need application in Tennessee requires the applicant to demonstrate, through independently verified data, that the community has an unmet need for the proposed facility. That demonstration involves a market analysis, a demographic projection, a utilization study, and a financial feasibility report. Each of those 4 documents is reviewed by a separate agency. The review period is 90 days, extendable by another 90 if the reviewing agency requests additional information. If a competing hospital files an objection, which competing hospitals are legally entitled to do, the process triggers a contested case proceeding before an administrative law judge. That proceeding has its own timeline, its own discovery process, and its own appeal rights. The certificate of need is one of 47 steps. It is not the longest one. China did not solve a different engineering problem, it solved a different calendar problem. The Hoshinshan site was a parking lot on the outskirts of Wuhan on January 23, 2020. The design was based on a template already in use, the Xiaotangshan Hospital built during the SARS outbreak in Beijing in 2003, also constructed in approximately 10 days. China had already run this experiment once. It had kept the blueprints. When the order came in 2020, the design team did not start from scratch. They started from a proven model and adapted it to the Wuhan site conditions in roughly 36 hours. What happened next requires understanding 3 things that most coverage of Hoshinshan never examines directly. The first is the supply chain architecture. China's major state-owned construction groups maintain standing contracts with material suppliers that do not require new negotiation for each project. The rebar, the modular wall panels, the prefabricated bathroom units, and the HVAC components used at Hoshinshan were not procured through a competitive bidding process that opened, ran for 30 days, evaluated submissions, and selected a winner. They were called in from existing agreements. The first delivery trucks arrived at the site within hours of ground being broken. Think of it as the difference between ordering from a restaurant where you have a standing reservation versus calling a restaurant you have never visited and waiting to see if they can fit you in that decade. The second is the workforce mobilization model. At peak construction, approximately 7,000 workers were on the Hoshenshan site simultaneously. They worked in shifts around the clock. This was not voluntary overtime in the Western sense. It was coordinated deployment of construction workers through a system that treats skilled labor as a mobilizable national resource in the way other countries treat their military reserve. The workers were paid. They were not coerced in any documented sense, but the mechanism that moved them to the site was state coordination, not market response. Within 48 hours of the project announcement, construction firms across Hubei province had been contacted by regional government offices and told how many workers to send, when to send them, and where to report. The firms complied. In the American system, a contractor receives a project award after a competitive procurement process and then spends several weeks mobilizing its workforce through voluntary hiring and subcontracting arrangements. The Chinese model compresses those weeks into hours by treating the mobilization as an administrative act rather than a market transaction. The third is what was absent. There was no environmental impact statement, there was no community consultation period, there was no zoning variance application, there was no utility easement negotiation, there was no review of the architectural plans by a municipal design board. The site was designated, the decision was made at the level of the state council, and the first earth was moved the following morning. Every approval that in an American city would require its own regulatory body, its own public hearing, and its own documentation trail simply did not occur. This is not an argument that those processes are worthless. It is an observation about what their absence makes possible. The American parallel to Hoshenshan is not a hospital. It is a field hospital. The United States military can deploy a field hospital, typically the combat support hospital configuration, in approximately 72 hours. It holds approximately 248 beds. It cannot be connected to a municipal sewage system. It cannot maintain negative pressure isolation. It cannot run a sustained ICU. It is a military asset, not a civilian one, and it exists precisely because the civilian permitting architecture cannot respond at the speed a military emergency requires. The United States solved the problem of emergency medical construction by creating a parallel system outside civilian regulatory jurisdiction. China solved the same problem by making the civilian system capable of military-level response when the state decides it must be. That decision point is where the comparison stops being simple. The Hoshenshan model does not translate to a liberal democratic system without dismantling the protections that make that system what it is. Community consultation, environmental review, and competitive procurement exist because the alternative is infrastructure imposed on communities without their consent, built on contracts that reward political connection over competence, and cited in ways that cause harm to the people who live nearby. The American record on all three of those failure modes is not clean, neither is China's. What the data shows, stripped of the political framing, is this. The United States has a hospital approval timeline that runs between 7 and 14 years for major facilities. China can build a fully equipped hospital from bare ground in 10 days when it decides to. The gap between those two numbers is not an accident of engineering or ambition. It is the gap between two entirely different answers to the question of who gets to say no. Here is the dimension of that gap that almost no coverage examines: what it costs in patient outcomes. The United States has a shortage of hospital beds that the American Hospital Association has been documenting since 2008. The shortage is not evenly distributed. It is concentrated in rural areas and in cities where hospital construction costs have made new facilities economically unviable under existing reimbursement models. In Mississippi, the state with the lowest hospital bed ratio in the country, patients in rural counties travel an average of 62 miles to reach the nearest hospital with ICU capacity. The Certificate of Need laws that govern hospital construction in Mississippi were designed to prevent overbuilding in urban markets. They have, as a secondary effect, made it nearly impossible to build rural capacity that does not meet the utilization thresholds required for approval. The regulatory system was not designed to produce a shortage. It produced one anyway, as a consequence of applying urban market logic to rural infrastructure gaps. China's response to its own rural hospital shortage has been the prefabricated township hospital program, a direct application of the Huoshanshan construction methodology to permanent civilian infrastructure. Between 2020 and 2024, China deployed over 1,200 prefabricated medical facilities to townships that previously had no access to inpatient care within 100 kilometers. The facilities are not equivalent to urban hospitals. They are designed for the specific case mix of rural populations: trauma, obstetrics, infectious disease, and chronic disease management. They are built to a standardized template, which means the supply chain, the workforce training, and the quality control systems are all already established before the first panel is shipped. A new facility can be operational within 3 weeks of a site designation. The American rural hospital system lost 146 facilities between 2010 and 2023, according to the Chartis Center for Rural Health. Each closure triggered its own regulatory process for Certificate of Need modification, asset disposition, and staff redeployment. In most cases, the communities affected had no alternative provider within the geographic radius that their state's Certificate of Need law had used to define their market area. 3 things look different now than they did at the beginning of this video. The first, the Huoshanshan construction was not a feat of engineering. It was a feat of pre-positioning. The blueprints existed, the supply chains existed, the workforce coordination mechanism existed. The 10 days was the execution of a system built over years. The hospital was fast because the infrastructure to build it fast had already been assembled. The speed at the end was a consequence of preparation at the beginning. The second, the American field hospital, is a confession. The U.S. military built a parallel construction system outside civilian permitting jurisdiction because the civilian system cannot respond to emergencies at the speed emergencies require. That is not a criticism of the military. It is a description of the civilian system's structural speed limit. Every country has a speed limit on civilian construction embedded in its governance model. The American limit is defined by property rights, environmental law, and democratic accountability. The Chinese limit is defined by the willingness of the state to deploy resources without consent. Neither limit is arbitrary. Both have consequences that extend well beyond the construction site. The third, the 11-year approval timeline at Erlanger, did not make the hospital safer. It did not make it better designed. It did not produce a better outcome for the community it serves. It produced a delay of 11 years. That delay had a cost measured not in dollars but in years of care the facility could not provide. No regulatory filing captures that cost. It does not appear in any budget document. It is simply the time that passed. And in communities where the nearest alternative facility is 60 miles away, the time that passes while the approval process runs its course is not an abstraction. It is the distance between a patient and a bed that does not yet exist. The human toll of delay is the loss of care when and where it is needed. China is now applying the same pre-positioned construction model to its rural hospital network, building prefabricated medical facilities in townships that previously had no access to ICU-level care within 300 kilometers. The deployment template is Huoshanshan. The question is what comes next when that template meets a problem too large for 10 days to solve.